Our next session will cover the topic of bleeding disorders. We can divide up bleeding disorders into the three key components of the formation of a primary clot and a secondary clot. We can look at vessel wall abnormalities. You can have platelet abnormalities, which can either be quantitative or functional, and then we can discuss deficiencies in the various clotting factors. Specific vessel wall abnormalities are particularly important to discuss because they're involved in a variety of pathologic conditions. Various types of infections, specifically bacteremia and even more specifically meningococcemia and endocarditis as well as rickettsial diseases, can cause the vessel wall to become remarkably deranged and therefore affect the ability to form and repair in the setting of infection and clot. Damage by these organisms and the immune response to the vessels of the microvasculature can cause this derangement. It can also be complicated by the overwhelming consumption of platelets and clotting factors referred to as disseminated intravascular coagulation, or DIC. Furthermore, various drugs that we use can cause vessel wall abnormalities, and you can have drug-induced antibodies to the various components of the vessel wall. And you can have deposition of these immune complexes within the vessel wall, which can lead to the formation of clot or to the inability of the vessel wall to adequately activate the clotting cascade. The collagen defects that we can specifically talk about, scurvy, vitamin C, and its effects on the ability to form stable collagen can cause mucosal bleeding, specifically gingival bleeding, as well as bleeding from under the nails, as well as Ehlers-Danlos syndrome, which classically causes the hyperdistensibility and the elasticity of skin. Henoch-Schönlein purpura is an autoimmune /hypersensitivity disease that can cause immune complexes in the vessel wall, which can lead to disordered coagulation and bleeding, and can cause a purpuric, non-blanching rash, specifically in the lower extremities. Hereditary hemorrhagic telangiectasia is an autosomal dominant disorder that leads to dilated and thin-walled or telangiectatic vessels that can also lead to difficulty in hemostasis. Amyloidosis causes amyloid deposition within the vessel walls themselves, and the vessel walls can become more friable and have disordered ability to assist in coagulation. Talking about the clinical pathology that you'll see in these diseases of the vessel wall abnormalities, they can cause minor bleeding, such as purpura or petechiae in the skin or mucous membranes, particularly the gums, as I mentioned again, in all of the above-mentioned abnormalities. Occasionally, more clinically significant bleeding, such as menorrhagia, epistaxis, lower GI bleeding, or blood in the urine may occur. It's important to look at petechiae versus purpura, and you can see the difference there, where the petechiae are present on the left-hand side and the non-blanching purpuric lesions are seen in the picture on the right. Continuing our discussion, moving from the vessel wall to the platelet itself, normal platelet function is vital to form a platelet plug to block hemorrhage from the damaged vessels. As we mentioned in the first section, the three steps involved are adhesion, activation, and aggregation. When you have a low number of platelets, you have decreased production or decreased survival of the platelets, which will inhibit the ability to adhere, activate, and aggregate in any significant measures when those platelet numbers become too low. There are functional disorders of the platelets in some of the membrane proteins that we discussed earlier, the glycoprotein 2b3a complex or the glycoprotein 1b complex. These can be inherited or acquired. So a discussion of the thrombocytopenia, a decrease in the quantity of circulating platelets. Any of the bone marrow disorders, aplastic anemia, bone marrow infiltration or myelothesis, with carcinoma, storage diseases, myelofibrosis, leukemias, or certain types of infections, which essentially cause a space-occupying lesion in the bone marrow, which inhibits megakaryocyte proliferation and maturation into a normal platelet. You can also have, in the setting of a myelodysplastic syndrome or megaloblastic anemia, a disorder in the production of megakaryocytes and maturation into platelets. It's very important to consider B12 and folate deficiency, some of the causes of megaloblastic anemias, as part and parcel to causing thrombocytopenia as well. There can be direct marrow toxicity via various types of drugs or alcohol, and some viruses, including HIV and the measles virus, can also cause disorders in platelet production. Some areas of decreased survival of platelets, if you have increased sequestration of the platelets in the spleen and increased destruction of platelets in the spleen, as was discussed in the lecture about lymphoid disorders. The spleen itself can be home to up to 1/3 of the circulating platelet population, and in the setting of hypersplenism can grow to even greater percentages. Idiopathic thrombocytopenic purpura, or ITP, can cause autoimmune destruction of already formed platelets in the setting of normal marrow production. So these platelets are produced normally, but don't live as long as a normal platelet would. There's also thrombotic microangiopathy, and these are all very life-threatening disorders. TTP, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, which is clinically very similar to TTP, as well as disseminated intravascular coagulation. The drug and HIV-induced thrombocytopenias are also idiosyncratic effects of various types of drugs, as well as the human immunodeficiency virus. So ITP is an autoimmune disease where antibodies against platelet membrane glycoproteins cause antibody-bound platelets to be brought to the spleen and cleared, which can lead to thrombocytopenia. Chronic ITP can be persistent in patients over a series of months to years. It is more common in adults with a male to female ratio of about 1:3. The clinical presentation can be a gradual onset of petechiae, or the skin lesions that we pictured earlier, larger lesions called ecchymoses, or mucosal hemorrhages, again specifically of the gingiva or of the nasal mucosa. The diagnosis consists of a complete blood count where the platelet count can be remarkably decreased. And it is a diagnosis of exclusion where we must rule out some of the other etiologies of thrombocytopenia, specifically the more life-threatening causes, and then we can determine whether or not this is idiopathic or immune thrombocytopenic purpura. The treatment of ITP is with steroids to try to blunt the immune response to the platelets, as well as splenectomy to remove the site of clearance of the platelets that are bound by antibody. Acute ITP is seen primarily in children and often follows an acute viral illness. This form of ITP is most often self-limited, and the thrombocytopenia is not as severe as seen in the adult form of chronic ITP, and oftentimes resolves within 6 months. If persisting longer, we do need to think about initiating treatment with some of the other medications or therapeutic procedures that we mentioned in reference to chronic ITP. The thrombotic microangiopathies commonly occur in the setting of sepsis or burns, or can occur as an idiopathic event following a bacterial infection. Features common to the thrombotic microangiopathies consist of extensive formation of microthrombi throughout the vasculature. And these microthrombi cause a shearing effect on the red cells and causing massive amounts of platelet consumption, which leads to the thrombocytopenia that we see in TTP and DIC. The microangiopathic hemolytic anemia is a direct mechanical shearing effect of the microthrombi, creating a net over the microvasculature. And as the red cells push through the microvasculature, they shear and become schistocytes that are seen on the peripheral smear. And we saw that peripheral smear in our lecture where we looked over some peripheral smears earlier. Here's another look at what schistocytes look like on a peripheral smear. You can see the normal-looking red cells around them, circular with a zone of central pallor. These schistocytes are remarkably deformed, and they look as if they are normal red cells that have just been cut, which essentially is what has happened to these on a microvascular level. So when you see more than one schistocyte per high-powered field, you need to be concerned about a thrombotic microangiopathy. Moving on to a discussion of TTP, the pathogenesis of TTP is generated by an autoantibody against the von Willebrand factor cleaving protease, or ADAMTS13, which can cause aggregation of circulating large multimers of von Willebrand factor because the von Willebrand factor cleaving protease is not present. So these unusually large von Willebrand factor multimers can create nidus for adhesion of platelets to the endothelium and activation once they are adhered. This can cause the formation of microthrombi, which leads to the cascade that we mentioned in thrombotic microangiopathies. TTP is usually acquired, but there are cases of congenital TTP. The classic pentat of symptoms in thrombotic thrombocytopenic purpura are fever, thrombocytopenic purpura, microangiopathic hemolytic anemia, and these can build up and lead into renal failure and altered mental status. TTP is nearly uniformly fatal if left untreated. And the treatment of TTP is plasma exchange, which does two things. It replaces the ADAMTS13 and removes the offending autoantibodies against the von Willebrand factor cleaving protease. It is also supplementarily treated with corticosteroids, but the key component of treatment, if given the choice, is immediate and urgent plasma exchange. Close cousin to TTP is the hemolytic uremic syndrome, which is caused by sepsis, particularly with enterohemorrhagic E. coli 0157H7, which makes national news every time there's an outbreak at a restaurant where people develop the hemolytic uremic syndrome. The Shiga-like toxins that are created by 0157H7 cause endothelial damage, leading to the extensive formation of platelet microthrombi and the consumption, which leads to thrombocytopenia. It's most commonly seen in children, and the signs and symptoms are similar to TTP, except the renal failure is more common and more severe, hence the uremic portion of the hemolytic uremic syndrome, and mental status changes are less common. Disseminated intravascular coagulation is the last of the microthrombotic disorders that we will discuss. It is particularly prevalent in the setting of sepsis, particularly with Neisseria meningitidis or E. coli. Malignancies also can cause DIC, but it's especially common in APL, or acute promyelocytic leukemia. DIC can also be seen in the setting of obstetrical complications in the peripartum period. Crush injuries can also cause disseminated intravascular coagulation, or specific types of snake bites. DIC is manifest by widespread activation of the coagulation system, hence disseminated intravascular coagulation. It leads to extensive formation of thrombi in the microvasculature, causing obstruction of flow, which is ischemic and toxic to the tissues. Also, clotting factors and platelets can be consumed in high quantities, causing an increased risk of bleeding, as well as a derangement of the coagulation parameters PT and PTT. Can also cause activation of the fibrinolytic system, which causes production of D-dimers or fibrin split products. The clinical presentation of DIC is petechiae, purpura, and mucosal bleeding in the setting of an underlying septicemia or crush injury or a burn. Laboratory findings include elevated PT and PTT, thrombocytopenia, schistocytes on the peripheral smear. You absolutely have to see schistocytes in order to call it disseminated intravascular coagulation, as well as elevated D-dimers and fibrin split products. The specific treatment for DIC is to correct the underlying disorder. So in the setting of septicemia, you need to treat with antibiotics. And DIC portends a particularly poor prognosis. The various types of drug-induced thrombocytopenias, we could spend hours and hours discussing them, different kinds of drugs that can cause thrombocytopenia. But for step one, the specific ones you need to know about are specifically heparin. Heparin causes a cross-reacting antiplatelet antibody to the heparin platelet factor 4 complex, which causes both platelet consumption as well as activation, which can cause paradoxical clotting instead of bleeding. So in the setting of heparin therapy, as you remember, the PTT will be elevated, but you can have arterial and venous thrombi that are formed abnormally. Antimalarials, specifically quinidine, can cause drug-induced thrombocytopenia, as well as sulfas, methyl dopa, penicillins, and the thiazide diuretics. HIV-associated thrombocytopenia is associated when antibodies against the HIV GP120 antigen cross-react with platelet surface antigen GP2B3A via molecular mimicry. This antibody binds the platelets, which are then cleared by the spleen. Let's go over a simulator question to cover what we've just gone over. A 76-year-old female finds small areas of hemorrhage on her gums and on the skin of her arms and legs. Lab results show normal PT and PTT. CBC shows a hemoglobin of 12.7, hematocrit of 37.2%, MCV of 80 femtoliters per red cell, platelets 276,000, and a white blood cell count of 5,600. The bleeding time is 3 minutes. Fibrinogen level is normal and no fibrin split products are found. What is the most likely diagnosis? Looking through, you can see that we can rule out liver failure because the PT and PTT are normal. In the setting of chronic renal failure or uremia, the platelet function is abnormal, which could lead to this situation, but they would give us information on her liver or on her renal function to make that the correct answer. Exposure to rat poison or warfarin would also cause an elevation in the PT. Metastatic carcinoma could cause bleeding disorder, but would also cause thrombocytopenia. So probably the right answer here for the gingival and petechial lesions that we're seeing is vitamin C deficiency or scurvy. That concludes our discussion. We will continue on with discussions of thrombotic disorders.